People are missing are coming in a while. Third part, today we are going to cover almost everything of direct restorations. We're going to perform 2 direct restorations on 2 posterior teeth. Here we have a model with MOD cavity on a first molar and occluso-mesial cavity on a second premolar. Okay, sorry. Usually in these very common cases, I used to perform a centripetal build-up technique. The centripetal build-up technique means that once you prepare the cavity, the first step is to transform the second class from a second class to a first class, building up the interproximal wall. There are several reasons for doing that. Contraction stress is lower down, and the most difficult part of the restoration, you do it immediately, and then you can think in a positive way during the whole restoration, and then you can manage also the anatomy of the tooth in a proper way. About the composites, in the posterior teeth, as I told you before, aesthetics is not that much important as in anterior teeth. Aesthetics doesn't mean shape, so I pay a lot of attention in shaping and modeling the composite in order to simulate everything of sound, real, normal tooth. So marginal crest, sulcus, fissures, triangular crest, everything. But the color is not the main problem. Consequently, we're gonna do 2 restorations now. On the second molar, on the first molar, we're gonna layer dentin and enamel shades. In case you want to perform and you want to mask as much as you can the natural color of the tooth. In the second premolar, we're gonna use just 1 shade of composite. The layering is anyway the same, so layer by layer we're gonna build up the restoration, but with the same classic color. And you're gonna see at the end that the difference in color will not be as big as you could expect, because it's not as in anterior teeth that the light pass through. In posterior teeth, the light cannot pass through because there is always tooth there. So I just have to remove my wonderful yellow glasses and okay. So first of all, we have to place the interproximal matrix. In order to obtain tight contact points, but in order to work as much more efficiently as you can, I used to apply all the matrix immediately. In these multiple cases, I use forceps usually, not fingers, of course. And then I will move the ring based on the tooth I am restoring. So once the matrix has been positioned, you have to place the wedges. On the upper, the wedges must be placed always not from outside to inside, but on the opposite side, because in the opposite side you see you have a bigger triangular space here, and you have to occupy the space with your wedges. The shapes depends on the amounts, on the dimension of the interproximal side you have. So here I think that a blue one would be okay, and every time you place the wedge, you have to keep with your finger or with your forceps or with an instrument the matrix blocked. Otherwise, when you push, the wedge will push your matrix over. I have not clear preference on plastic or wood wedges. Actually, I think that wood wedges are most easiest to adapt because they are softer than plastic ones, but they work in a good way. Remember that with the sectional matrix, wedges needs the use of wedges is because of adapting the matrix to the cervical area of the cavity. So down there. So once you place the matrix and once you place the wedge, before placing the ring, you just have to check that you do not have space here in between the cervical ridge of the cavity and the interproximal matrix. And then that your matrix must be stable. So if you touch it, it moves here, but it doesn't rotate and it doesn't move from vestibular or palatal directions. Once you have that, you can place the ring. The ring must be placed opening them as much as you can and then closing slowly in order to avoid that the matrix is pushed in between the interproximal area. If you do it immediately, the matrix is closed in between and you can have a problem here. Okay, we're gonna start with the premolar. In these cases, the other suggestion I can give to you is to immediately perform the adhesive procedures on both the cavities, because if you are going to do first here and then here, and if you perform adhesive system here, leaving this cavity with dentin drilled, exposed but not etched and not with adhesives, this collagen will collapse and this tooth will be a lot dehydrated, and so you could have a lot problem of post-op sensitivity. So independently on the cavity you are beginning, which cavity you are beginning to fill, we can use bonding raising on both. Technically, in a real tooth, I would create a selective enamel etching. We don't have enamel here, but selective enamel etching and then self-etch approach, because as I told you before, today the best option for dentin is self-etch approach, is less operator, less post-op sensitivity, is less influenced by the expertise of the dentist. The only things you have to do is to brush. It's better to waste 10 seconds more on this step instead of performing again the restoration because the patient is painful or you have infiltrations. So in this case, you apply your bonding, then you dry it with air. I can blow. Don't do that, really, please. and then you brush again. You see, I do not place new adhesive. You already have a lot of adhesive still in the brush. Okay? Don't waste material, they cost a lot. Use that, but don't waste that. So, once you brushed properly, and blow it again, light cure. And remember that because of the distance between the curing tip and the bottom of the cavity, the step that needs the higher curing time is the adhesive curing, because it's the part of your restoration which is most far away from the tip. So it's better to cure 10 seconds more the adhesive than the composites is gonna be arrive in a while. Let's get another drop of universal adhesive. Let's imagine we had pre-etching of the enamel, and let's place again the bonding resin everywhere. And here the procedure is again the same, so be precise and meticulous in applying a lot of composite bonding agent everywhere. Blow again and then push it again. We saw the procedure, and light cure at least 20 seconds. Okay. Whoa. Now of course we start with the interproximal wall here. Just check that the shape of the matrix is perfect. So you have to check that it closes even the floor of the cavity, even the actual walls of the cavity. And then with a single layer of composite, you can place it and you can start pushing the composite towards the matrix very slowly in order to create the interproximal wall. First, you have to take care to close the bottom of the cavity. Okay, once you create the wall, you see that here you have composite which goes a little bit higher, and it is correct because before curing it you have to do these movements in order to create the part of the tooth that of the marginal crest that begins to turn towards the occlusal surface. And any matrix can simulate perfectly that. You have to do that with a thin spatula. And if you regulate the right amount of composites, you will obtain a very, very, very thin interproximal wall. Light curing. And once you light cure, before removing the interproximal matrix, I always suggest to place a thin layer of flowable composites. Flowable composites on the dentin cavity gives you several advantages. You must apply a really thin layer, okay, 0.5 maximum. But first, if you add some little areas which are not perfectly closed there, the flowable composite will flow there and will seal perfectly even what you cannot see with your eyes. Secondly, you reduce the contraction stress of the composite towards the dentin that will come later while curing the composites. And third, the cavity walls becomes more sticky than the spatula, and so the composite stays where you want to place it inside the cavity and does come back with your spatula always. Okay, you just need to place a little quantity. I used to place a little drop here, and then with a little pointer you just bring it even inside the proximal area in order to distribute it along all the cavity walls. I always use flowable composites as a first horizontal layer in cavities. Once you did it, I changed the program, I think. Okay. You light cure it, and then you can remove the ring. Technically, you can even remove everything. I just suggest to remove the matrix without removing the wedge. Why? Usually bleeding. Yes, it's if you have an interproximal matrix caries, you have for sure gingiva which is inflamed. So let's leave it there, and we can immediately move to perform the other two. Okay. In this case, you can even apply both this one and this one. You can even apply both the rings, and you see that you can easily goes inside the cavity to build up the interproximal wall. The procedure is exactly the same, so I move faster than before. You must be gentle in touching the composites in order to let the composites adapt to the cavity. Okay. Once you have this, light curing, just to fix it. In reality, don't save time with light curing. I think I told you 10 times today. And then again, enamel shades on the mesial wall. Adaptation of the composite to the matrix. Again, one, two, check that you closed everything, okay, and then light cure. Again, flowable composite along the wall cavity everywhere. Few quantity of flowable. Light cure. Okay, and we're gonna remove everything. Here we are, and we have the 3 walls. Now we have 2 first class, and it's easier to proceed with the restoration. So let's come back to the second premolar, and let's start layering with an oblique technique. So you just have to push, and I used to take care first of one side and secondly to the other side. So first I shape the palatal side of the cavity, and then I will shape the vestibular side. With the spatula, usually we have already the tooth which is telling us the anatomy. So just follow like this the anatomy, placing the first layer of composite. Just 2 little circles there because of the premolar shape, and then I used to work also with little brushes in order to have a better adaptation on the margin with more gentle instruments. Once you check that the direction and the inclination is correct, light cure. This is a really small cavity with 2 layers. We will complete it. You can perform your restoration on the other side. A little bit of composite is missing. Once you get the adaptation on the floor, you have to remove slowly the excess. Following the residual crest. Pay attention of the composite who can drop inside the marginal area. And then you just have to design 2 fissures. And the brush here helps you a lot. Okay. That's done. Let's do the layering of the second class cavity on the molar. Dentin shade. Here, because the cavity is bigger, I proceed cusp by cusp. Even with the dentin and even with the enamel. If you want to layer the two colors, you need to remember that you need to leave space for the enamel over the dentin, and thus you adapt it, and then with a round shaped instruments you just have to push a little bit downwards the composites in order to free the margin. Okay. And then light curing just to fix it. I think this patient is gonna bite anything this evening. The other attention you have to pawn is in having the composite who is touching one wall only. If the composite touches the opposite wall, you are not solving or limiting the problem of contraction stress on the posteriors. So, adaptation. And also in the dentin layer, you start with modeling everything, beginning to following the anatomy of the tooth. The anatomy starts from the dentin. The other suggestion is to immediately remove the excess. And light cure. Fourth layer. It's always the same procedure. Here we have a little bit of too much dentin. And thus you can move it. And then you come back again with the brush. And then with little points. Beginning to give the anatomy. Here we are. And now last dentin layer. Again, first pushing down the composite in order to close all the cavity. Secondly, distribute it in order to leave a space for the enamel, which is going to arrive in a while. And we are gonna already give anatomy. Here we are. And we have the dentin shades. I can remove this. I think it will not bleed. And now we're gonna miss just the enamel. If you already shaped the dentin layer, the enamel is easier to place out because you already have a project to follow. The only thing you have to do is with a spatula, follow the inclination of the crest you have. And again, I prefer to work cusp by cusp. It's gonna take you 5 minutes more working cusp by cusp now, but it's all time which is saved in the occlusal check, because you can work better in giving the right shape, which is automatically an advantage is in occlusal contacts. That's it. Following the triangular inclination, crest inclination, approaching the composite toward the center of the restoration. Designing the anatomy. Okay. And just find back the initial sulcus I performed in dentin. In order to have the correct shape even of this part. Last two layers. always working in the same way. If you want, in posterior, you can use the brush. Pay attention to the brush for two reasons. First, the brush always leave in a while black dirty parts, and secondly, in anterior teeth you have to avoid to use the brush with the adhesive on it, because you get a yellowing effect because of the camphoraquinone. The camphoraquinone is yellow, and if you use the brush for the composite adaptation, you increase the amount of camphoraquinone on the surface of the composite, and the consequence is a yellowing effect that will result in not a perfect color adaptation of your restorations. Okay, let's just fix a little bit here. Fossa, that's it. Fourth part and last, and then you have already to close there. As you can see, the most useful tools for posterior, but in general for composite layering, is this one. Okay. Okay, just the palatal sides of the cavity. And we just need then to finish and polish it, which is a key point of restorations, always finishing and polishing procedure. Then at the end you just need to clean the brush with alcohol. Okay. Okay. I think we get the point. While I have just to complete, you know that I am a little bit maniacal in aesthetics, and so why not a little bit of brown in the sulcus? But in order to work, you need to design the sulcus. So you just place a little drops inside, and then you remove the excess with a brush. Okay. As last layer, because this is the last layer, now we just miss to light cure for the last time, and then remember the OxyGuard, so the glycerin gel, to avoid the dispersed phase of the composite, which is the oxygen inhibited layer. And then we move to the finishing procedure. In posterior second class restoration, for finishing procedures, I always use discs, always. Okay, it works. I will try to save my fingers. And I prefer to work with disc slowly, because the first step is to finish the proximal areas. Even because in this area you always have excess not only of composite but also of adhesive. Of course, this one goes only around the contact point, not inside the contact point. That's why the end piece must work slowly. You don't have to have a full pressure on your foot control, otherwise you're gonna open the contact point. And this is the only thing that patients understand on their posterior restorations, if the foot goes in within the contact point. Then blow, and you can just rise down in grain size of your disc. In order to have also a polishing effect. Remember that if you have some excess on the occlusal margin of your restoration, you can also use red ring diamond bar just to remove along the margin the excess of composite. Okay. Once the interproximal area is almost completed, you just need to move to polish. I think that I was wondering when companies would have give us proper polishing systems, because I think that all the shape of the pointers before were not able to reach all the areas of the restoration, while the spiral like this, they can easily reach everywhere. You have two colors. The first one is more aggressive, is to remove the excess and start cleaning. So this one has a more polishing result. Okay, you can collect a lot of debris, no problem, because once you pass with the other one, you will clean the cavity and you will clean all the restoration. Here we are. Okay, just a little bit of adhesive to clean up the remove the debris. In reality, here, just to cleaning and removing the debris, I use a little bit of alcohol. Because I spent minutes to create wonderful anatomy, occlusal and sulcus, and it's a pity that they becomes blue because of the silicone. Brown is natural, blue is not natural at all. Okay, but here we can just pass an adhesive to obtain the same cleaning effect. And then we just have to go with brushes to clean everything up. I just want to even check before if you don't have any excess. Yeah, here you have one. Before completing and passing on the polishing and glossing procedure, just control that you do not have any extra amount of composite over the occlusal margin. And in reality I used to remove this amount of composite, which happens to be out of the on the occlusal surface, with a red ring bar, as I told you. Okay. Now these are okay, and thus we can move to the brush, which is mandatory, of course, for having a polishing effect. Remember that while you are doing that, you should blow air on the teeth. Otherwise, you are going to cook the pulp, making a pulp grill. But I think that here we don't have the same problem. Here we are. So this is a simple step-by-step procedure to perform 2 restorations or 1 restoration. It depends on the case you have, with which you don't need then to spend a lot of time for occlusal check, because if you're going to see on this view, you see that the inclination of the triangular crest just continues the natural inclination of the occlusal condition, and thus you don't need probably to have a big correction after occlusal control. And this is the step I hate above all, because after this, in a reality, it passed 1 hour, you are working for 1 hour in the same teeth, and once you finish, you just want to push that patient away from your office. You are awful of that. And if you still have to say, is there I do not bite perfectly, and then check, you probably pay attention the first time, and the second time you pass the bar inside the composite and you disrupt everything because you don't carry it anymore. But you spend 1 hour working and you will ruin that working in 1 second. So let's spend 5 seconds more, 5 minutes more in giving correct shape and correct angulation of every area of the posterior restoration, in order to have a restoration which is already done when you finish, in order to do not need a lot of work once you remove the rubber dam and once you let the patient goes away. The only last step you have to do, sometimes if you have a little bit of excess under the occlusal contact here, you just have to pass or an interproximal strip, just cut it, divide the interproximal strips we used to have, they are too much high. So my assistant, she knows, and she cut them in two. So I have thinner interproximal strips that can pass easily only down the proximal contact in order to remove eventual excess of composite here and here. Another tool you can use to remove the excess here is the scalpel, the number 12 scalpel, which is a round shape, and you cut there and you remove the excess there. So I think that it's done. I cannot see anything anymore. And if you have any questions, feel free to ask, of course. But I think that these two restoration could work for a long time. Okay? 1 hour, perfect. Come on. I see one hand rising. Yes, okay. Because I'm a little bit blind because of the light. So.
When is the right time to use again? After the
To use
oxygen.
Okay.
After the last service, after the polishing, after the
Before the polishing, before the finishing and the polishing procedure, you completed the restoration. You placed eventually the brown, okay, so it's done. You light cure
with oxygen?
without OxyGuard, so you place the last layer of composite, okay? You light cure the last layer of composite, you check, you do not have to add any more material over there. You place the OxyGuard and you light cure again. You have to do it in posterior and above all in anterior, because if you do not do that, you start finishing and polishing, but you are not polishing cured composite. You are polishing uncured composite, and so you will not have this kind of glossy surface you can have with the OxyGuard use. So it's really mandatory in anterior teeth, of course, because otherwise you can stay hours with the brush like this, and you will not obtain any glossy surface, because there is the monomer which is uncured on the top of the surface. So you light cure the last layer, place the gel, and light cure again. 10 seconds, 10 seconds. Okay, I think now you will perform wonderful restoration from next week and over. From Monday, yeah? Thank you. I can take a picture.